Good afternoon, Vidya ma'am. I hope it's audible to all.
Yes.
So welcome all to our fourth session.
Now I can hear you. Yeah, I can hear you now. I couldn't hear you. I thought you were talking. Good afternoon, Dr. Sunil.
Hi.
Hi.
So welcome to our fourth session. So we can start with Vidya ma'am's presentation. It will be extending to 40 to 45 minutes, followed by a brief discussion on it. By 4 o'clock, we can start our case presentation, followed by its discussion. We can wind up our session by 4:30. So thank you all for joining in. I hope you will enjoy the session.
You'll have to, Rajalakshmi, you have the PPT, right?
Yes, ma'am.
I think I mailed it to you. Yeah, just Dr. Sunil, would you like to?
Yeah. Today it is going to be a very important session because in pain management, opioids are one of the mainstay of treatment, especially in acute severe pain. So this session will be handled by Dr. Vidya Viswanath, who is the Assistant Professor in Palliative Care at Homi Baba Cancer Research Institute in Visakhapatnam. And she has been cooperating with us for taking classes in the SECO since long time. And I welcome Dr. Vidya, and it's over to you.
Yeah. Thank you very much, Dr. Sunil. Rajalakshmi, will you be scrolling the slides? Can I see the, instead of a full screen, can I have it so that I know the next slide that's coming on? Because I'll not be able, yeah, if this is all right, I would like this.
Okay, sure, ma'am.
Yeah, sure. Now, very good afternoon to all of you. I hope I'm audible. This session will involve a little bit of pharmacology, a little bit of understanding about the opioids, because we do not have too many drugs in palliative care, but opioids are the mainstay. So it helps if we understand and think and know how to dose, because in opioids, the most important thing is that the patient also needs to understand the dosing. So at the very beginning, before we even start the opioid, it is not the answer to every kind of pain. So a proper assessment of pain is one of the most important things. So when we assess pain, what we mean by assessing pain is actually trying to figure whether this pain is going to be opioid responsive. So understanding whether it's nociceptive, whether it's neuropathic, and small clues given by the patient. If the patient comes to you and shows you a tablet of tramadol and says that this tablet is making me drowsy, it's not helping my pain, that is a pointer for you that opioids may not be the mainstay for this patient. So listen to them, take a history, tell them to take out whatever medications they have been taking in the past, what has worked for them, what has not worked for them, assess that pain, and if it is opioid responsive. Now, if you have a woman who's come to you with a splitting headache and vomiting, she is a triple negative breast cancer. In that case, that headache may never respond to opioids because it could be due to increased ICT. So as you give your opioids, you should also think whether this pain will respond to opioid or not. So knowing what are opioid responsive pain is also important. And prescription of opioids, the most important rule is prescribing the adjuvants, because many a times, whenever we give opioids, we always give a step 1 drug. You must have learned in the WHO step ladder, it's usually combined with a step 1 drug. More importantly are the adjuvants. What we mean, I think there's someone who's not muted.
So please mute while you are logging in.
Yeah, there's someone who's not muted and there's some disturbance in the background. So if you could do that, it'll help. Thank you. So when we talk of adjuvants, opioids cause severe constipation, and you cannot just say that if your bowels don't move, take something. That doesn't work. The hand that writes the prescription for opioids should be the one that writes the prescription for laxatives, for antiemetics, and sometimes you may need adjuvants to correct the other kinds of pain that are associated with it. So that is another important part. All pain cannot be corrected with that one opioid prescription. There is a huge role for disease modifying therapies also. When we talk about early palliative care, it is also important to understand that disease modifying therapy and palliative care will go hand in hand. So many times your bone pains, you can have bisphosphonates which help for bone pains. They are more of adjuvants. Chemotherapy, radiation, all of these can help in controlling pain. And these are all the physical aspects of pain. But the most important thing as a palliative care physician, or when you are managing pain in a patient with chronic disease, is managing total pain. And when we say total pain, we mean the physical, the psychosocial, the emotional, and the spiritual aspects of that pain. If anxiety, if the social factors are not addressed, if that spiritual distress is never addressed, no amount of medication will correct that pain entirely. So before we prescribe opioids, this is a small checklist that you need to go over in your mind and then start your prescription. Next slide, please. So this is something all of you are familiar with. Today, my talk will be mainly focused on that step 3 in the ladder. Next slide, please. So this is our Mr. X. His face tells you how much pain he is in. When you ask him, next slide, please. He tells you that he's 56 years old. He has severe pain around the neck. It is a 10 on 10. It is a sharp kind of pain. And he doesn't have, it's not radiating anywhere. And in the last 2 weeks, he's been unable to sleep. Now, it's important to assess pain, find what is happening. But the first thing that you need to do in him, next slide, please, is you have to relieve that pain and then talk to him. And this is how his face can look if you give him a trial and relieve that pain. Next slide, please. So what did we just do to this person to give him that much pain relief? So when we have decided, now this is 10 by 10, this is non-radiating pain, this is in the neck, and it is secondary to his disease, then morphine is the step which we will go to straight away. Now, just because you are seeing the patient for the first time does not mean that you have to start from step 1, go to step 2, go to step 3. So even if you're seeing the patient for the first time, if the pain score is severe, and if this patient's disease you think is opioid responsive pain, he has not been given, you have to give him a trial with morphine. And that will help you decide what kind of dosing you can give this patient. So when we talk of a morphine trial, there's something called an intravenous morphine trial. How do we do this? Morphine causes a lot of emesis, so you first need to inject metoclopramide 10 milligram so that he does not vomit. Then you inject morphine 1.5 milligram at 10-minute intervals. The end point is pain relief or sleepiness, whichever is the first. The next slide, please. So you maintain a chart like this. So when you maintain a chart like this, Jitin, if you don't mind, I would like to keep it this way because then I know what the next slides are, as I have to tell someone to, I have to tell Rajalakshmi to move my slides. So the presentations will be coming to you. So when we are talking of an IV morphine trial, we need a chart like this. So in this chart, we note down the time. So assume that this is 10 a.m. So at 10 a.m., his pain score was 10 on 10. He was not drowsy. We gave him 1.5 milligram of morphine. The next, after 10 minutes, his pain score has come to 7. He is still not drowsy. So we give him another 1.5 milligram. At 10:20, his pain score is at 4. He is still not drowsy. We have given him another 1.5 milligram. At 10:30, you saw that second picture of that man. He felt relieved. His pain score was 1. He was still not drowsy. And that is when we stopped giving him the morphine. Next slide, please. So what have we done? we have given him 4.5 milligram IV morphine, and this has given him good pain relief. So if we need to convert this into the oral dose, we take the nearest dose, and that becomes the 4th hourly dosing. So 5 milligram, next slide please. So 5 milligram Q 4th hourly now becomes his dose. So just telling him 5 milligram every 4 hours and sending him is wrong. So what we have to do is draw this little chart and say that at 6 a.m. please take half a tablet. 10 a.m. half a tablet, 2 p.m. half a tablet, because the lowest strength that we have is 10 mg tablets. So 6 p.m. half a tablet. At bedtime, he needs to take 1. Why does he take 1? Because from 10 in the night to 6 in the morning, it is an 8-hour interval. We don't want him waking up at 2 a.m. in the morning trying to take a morphine tablet. But the most important part of the prescription is that last column, which says take half a tablet SOS whenever needed. How do we decide the SOS dosing? The SOS dosing is always the 4th hourly dosing. So the dose that you give every 4 hours is the SOS dosing. So whenever you prescribe morphine, it is a Q4 hour dosing plus an SOS dosing, which is used for breakthrough pain. Or suppose he gets pain at some odd time, he still has to wait for the medication at that particular time. He need not suffer in pain. He can take the tablet, and tell them to maintain a small pain diary where they tell you how many such SOS doses are needed in one day to give them optimum pain relief. You have to explain that the SOS is separate from those of the timing. Otherwise, some of the patients will come back to you and they'll say, oh, I took SOSs this time. I started calculating 4th hourly from there. So you have to make it very clear to them that the 4th hourly dosing is a different set. The SOS is different. If you are explicitly clear about this to your patient, then they will be able to manage the dosing themselves. The most important thing is review the next day. You may not be able to review all patients in person, so you might have to do some phone reviews. Next slide, please. Now we imagine a busy OPD where you're seeing say 25 to 30 patients every day, and then you will not have the resources nor the time to give an IV morphine trial to everyone, right? And plus when you break one vial, after that, what will you do with it? Can you keep it for another patient? You have a lot of logistic issues also. So that is why very commonly in our OPDs, we use what we call as an oral morphine trial. So suppose this patient has come to you and he's telling you, I'm taking an Ultracet SOS, I'm taking 2 Ultracet a day, or I'm taking some tramadol, some aceclofenac combination. Usually they'll come and tell you these combinations. So when we have decided we want to start opioids, we usually start with 5 mg. So half a tablet, and I usually give them Paranorm even before, let them take it, and then give them half a tablet of morphine. And tell them to come and tell you how they feel after 45 minutes. So first you give them a visual analog scale, you grade the pain score, you take the pain score. He tells you my pain is at an 8 on 10. So you give him this 5 milligram, tell him to come to you in 45 minutes and then tell you what his pain score is. So yes, the duration of time will be longer than the IV, but it really works well in an OPD where simultaneously you will have 2 or 3 more patients who have been given an oral morphine trial. Next slide, please. So now our Mr. X was started on 5 milligram 4th hourly and SOS. He was relatively pain-free for 2 weeks. But then he comes back to you and says, I need 4 SOS doses, which means what? He needs 4 times he takes an extra 5 milligram. So now what do you think we should do? Anyone would like to shout out the answer? What do you think we should do? Would you like to increase his dose? Because you can't have somebody taking 6 times a day taking morphine and 4 SOS doses. So what we need to do is we need to now increase his dose. So we will make it 10 milligram Q4th hourly. All right, next slide, please. So the rule is that when 2 or more PRN doses are taken, we can increase the dosage by 30 to 50% every 2-3 days. So because this man came and told you, I'm taking 4 extra doses, I just doubled his dose. All right. So that now he is on 10 milligram Q 4th hourly. Next slide, please. Now, how frequently would you give SOS doses of morphine? Yeah, somebody has sent a message saying you can calculate the per day dose required and then divide it and give. That works fine. Only thing is you have to take the average, because if one day they're taking 4 PRN doses, the other day they're taking 2 PRN doses. So you will have to know they may not be, and if within 2 days you may not be able to get the exact dosing per day. It always takes about a week to stabilize. So that's why we say 2 extra doses, 30 to 50% increase. 4 doses, you can double it. So how frequently would you give SOS doses of morphine? And why can you give it? Now, why is it that this is one drug where I don't really calculate body weight? I don't really have what is called as an upper limit. I comfortably tell the patient, take your SOS doses, come and tell me how much you've taken. You decide how much you want to take, if it is helping you. If you are drowsy, then you stop taking it. Why is it so different? So that is where we need to understand a little bit about what morphine is. Next slide, please. So this is the most important opium. It's a poppy alkaloid. We make a lot of it in our country and most of it is exported. Next slide, please. So when we talk of the pharmacokinetics of morphine, how does this drug affect our body? It is absorption. How does it get absorbed? How does it get distributed in our body? How does it get metabolized? And how does it get excreted from our body? The basics of this, if we just try and understand, then it becomes easier to prescribe. Next slide, please. So in the absorption, you have first, after the medication is swallowed, it goes into the gastrointestinal tract, into the blood vessels, the portal vein, liver, metabolizes. So this is your first pass hepatic metabolism before it enters into the systemic circulation. Next slide, please. So most of the metabolism is in the liver. There is some part which goes on in the GIT and the kidney. 90% of the drug are metabolized. So you have M3G and M6G, morphine 3-glucuronide and morphine 6-glucuronide. So it is this 6-glucuronide, which is about 5 to 10%, which is the active component. And that is the part that gives pain relief. Next slide, please. And it is in the upper small bowel, the alkaline medium of the upper small bowel, that this absorption happens. So it is a hydrophilic drug. It has a slow onset of action and it has a long duration of action. Okay. But suppose you decide to give this drug subcutaneously, or you decide to give it intramuscularly, it goes directly into the bloodstream. It escapes the first pass. Next slide, please. When you give it sublingually, see, we can give this drug sublingually, we can give it rectally, and we can also crush, and we do it quite often. We crush it with a little bit of honey and put it in the buccal mucosa or in the mucosa, especially when we tell patients to manage at home and they're really far away, they have no access to anything else. So sublingually, the absorption is low. Buccal and gingival also, there are different findings. It has a bitter taste, so we usually tell them mix it in honey, a little bit of honey, and then put it. The contact time should be almost 6 hours for them to get some kind of an effect. Next slide, please. So intravenous is among the most effective routes because the drug is 100% bioavailable and you eliminate the entire first pass hepatic metabolism. Next slide, please. So when we talk of what is bioavailability, it means how much of the drug am I giving and how much of it is being accessed unchanged into the systemic circulation. So this is the percentage of administered drug with excess unchanged to the systemic circulation during oral administration. The next slide. So what gets absorbed and what is bioavailable is not the same, because if you're going to think of how much of morphine gets absorbed, it is 100% absorbed. But when you give it orally, what is the bioavailability? It is 20 to 40%. Next slide, please. Now we talk about 4th hourly doses. So there are times when it can be difficult for a patient to take doses every 4th hourly. So do we have another option? So we call this as short acting morphine. It's not immediate acting because it takes about 40 to 45 minutes for the action. So we also have what we call as controlled release preparation. And in controlled release separation, they come with a coating. So what happens is you achieve the expected absorptive profile. And to do that, it needs to remain at a prolonged length of time. But suppose this drug, if you have something like a stoma, or if you have to crush the drug and give, the patient cannot swallow the drug directly. You cannot give them a controlled release preparation. So controlled release preparation, usually we calculate the daily dose. So if a patient is taking 5 milligram Q4th hourly, his total daily dose is 30 milligram. If a patient is taking 10 milligram, now our Mr. X was taking 10 milligram Q4th hourly. So his daily dose in 24 hours was 60 milligram. So it is 60 milligram. Can we give it to him in 2 divided doses? We can give him 30 milligram BD. So that's how we usually calculate and give the controlled release preparations. But the note of caution here is, next slide please, that do not, you should always tell the patient that they should not crush the medication, should not bite it, should not chew it, and they should just be able to swallow the medication. Otherwise, a controlled release becomes a immediate release preparation, and it can be worse for the patient because a large dose gets immediately released. The different preparations that we have of morphine, we have aqueous solutions which are available in very few places, and tablets which are immediate release and controlled release, and the injectable form which is 15 milligram in 1 ml. Next slide please. 1.5 milligram in 1 ml. Next slide please. So we have Mr. X, he was now on 10 milligram 4th hourly. Suddenly they bring him to you and you find that he has excessive drowsiness and he has a serum creatinine of 5 milligram per deciliter. So now, will you do anything with the morphine dosage? Next slide, please. So your first instinctive reaction, stop the morphine, don't do that. Why should we not do that? Just to understand that, let's just run through the excretion of the drug. How does this drug get excreted from the body? It goes through glomerular filtration, M6G accumulates in renal failure. So that is why what happens is the clearance is decreased and half-life of the drug is prolonged. So now, how can we still continue giving the drug to Mr. X? What we can do is, we can increase the spacing. So instead of giving him at 4th hourly intervals, we can make it 8th hourly intervals. So instead of 6 doses a day, we'll give him 3 doses a day. And what we can also try and do is reduce the dosing. Come down to say 2/3 of the dosing. See how he feels. Add adjuvants. Instead of morphine, you increase the adjuvants. Or the ideal way to do this is to switch the opioid. Because the first choice opioid is not morphine in renal failure. So here, if you have access to fentanyl, you can switch to fentanyl. But if the patient cannot afford fentanyl transdermal, which is what happens in most of our patients, because both the options, fentanyl can be very expensive. And if you are lucky to be in a center where you have methadone access, you can probably shift him to methadone because that's a cheap drug. You can use it in renal failure, but you should be very, very careful about titrating, which is another bit in itself. So our first thing that you can do before you even think, before you even talk to them, before you know whether you have access or not, is increase the spacing. So increase the spacing, make it an 8th hourly dosing, and try and bring down the dose by at least 1/3 first, add adjuvants to step up for that pain control. Next slide, please. So now Mr. X was sent home. He's taking his morphine 10 milligram 4th hourly. After 2 months, he is not able to swallow anything, including his morphine. So now patients, especially with maybe oral cancers, or sometimes they go into, say, hepatocellular failure, or sometimes they are unconscious with brain mets, but they have been on some dose of morphine. So how are you going to cope with these patients? How are you still going to give them pain relief? Next slide, please. So you have various routes where you can administer morphine. You can have the intravenous, the subcutaneous, the oral, per-rectal, epidural, and intrathecal routes. The next slide, please. So when we, all right. So when we give it intravenous or subcutaneous, you have to be, that slide comes in somewhere later, but the word of caution is, you first measure the daily dosing. Suppose he's on 30 milligram per day, then you have to halve that dose when you're making the route subcutaneous. You have to make it 1/3 when you're making that dose IV. So don't give the same 24-hour dosing. There is a difference between the oral, the subcutaneous, and the IV dosing. Now, this is a bit about morphine, how it gets absorbed, what happens. And there are other drugs in the step 2 and 3. So there are sometimes challenges as to how do you choose the opioid or how do you choose a drug. So I'm just giving you all these two hypothetical scenarios. One is Mrs. X. She is on a 50 milligram Q4 hourly morphine. She comes to your clinic with a severe episode of pain. Instantly, you have injection pentozokin. You also have oral morphine. But how will you manage this patient? Is there any role for anything else? Another situation is you have Mrs. N. She has had breast cancer. She's got brain metastasis. She's received radiation to the brain. She has just come to you and she says she has moderate pain. So her pain is, say, 6 on 10. So how will you manage this patient? So how do you choose which opioid to give? Next slide, please. So when we talk of opioids, it's more or less like a general term. So it includes naturally occurring, it includes semi-synthetic, it includes synthetic drugs like methadone, and all of them produce their effects how? How do you think opioids act? They combine with opioid receptors. Next slide, please. So the receptors for these opioids are the mu, kappa, and the delta receptors. Next slide. So these opioid receptors are found in several areas of the brain, in the spinal cord, and in the peripheral nervous system. Next slide. So some of the opioids that we'll just run through are codeine. Now, when we talk of potency of codeine, it's 1/10 as potent as morphine, and it's a prodrug of morphine. The bioavailability is 40%. It takes about 30 to 60 minutes to start acting, and it acts for about 4 to 6 hours. But in our parts, we hardly get codeine. We use it, next slide please, we use it for cough. We use it for pain relief and as an antidiarrheal, but its most important role is for cough, though we hardly get it anymore. So nowadays we use oral morphine even for cough, because finally codeine is a prodrug of morphine. Next slide, please. Dextropropoxifen, the principal metabolite again is not propoxifen. The potency is 1/12. Duration of action is 6 to 8 hours. Next slide. Tramadol, what we use very commonly, its action is on opioid receptors, but along with it, it also inhibits the reuptake of serotonin and noradrenaline. So that is why it has a little bit of an extra effect, and that helps in the neuropathic pain. So that is why when you have a patient who's complaining, who gives you both nociceptive and neuropathic pain of moderate intensity, tramadol will work well. Next slide, please. The potency of tramadol, this is another thing to note before you actually take an injection and give injectable tramadol, which we see very commonly being done. The potency is actually 1/10 that of morphine when it's parenteral and 1/5 when it's oral. The bioavailability of tramadol is much higher when you give it orally. It lowers the seizure threshold. So whenever you have patients who give history of brain metastasis, or whom you're suspecting brain metastasis, who have been on who have been given WBRT, who are on anti-epileptic therapy, in these patients it's better to avoid tramadol because it lowers the seizure threshold. And nausea is one of the most important dose-limiting side effects. Patients throw up really badly, so it helps to give a good antiemetic before you give tramadol, or initially when you're starting the medication. Many times we see injectable tramadol just being given and the patient is throwing up so badly. The duration of action again is 4 to 6 hours. Next slide, please. Fentanyl, which many of you must have seen, the transdermal patch which is being used, and those of you who are in anesthesia must have used the intravenous form. We also use it for pain control. It's a lipophilic drug, and the fentanyl transdermal patch is pretty common, and I mean we see it being used more than oral morphine, which is actually not right. Next slide, please. So what does this patch do? It forms a subcutaneous depot. But you can't just stick a patch and say now your patient will be pain-free. Doesn't happen, because it takes 12 hours for that patch to build that depot and that drug to get deposited. So whenever you're starting fentanyl, you have to spend an extra couple minutes to talk to the patient, because you need to tell them that the first 12 hours when you have stuck the patch on, your pain control will not be there. So you will have to use the medications that you were using. So if you have been on oral morphine, continue it for the first 12 hours. And after 12 hours, please take SOS doses of morphine. Because don't just stick the patch and tell them, okay, now you'll be pain-free. It does not work. So you have to give them good analgesia for the first 12 hours, preferably continue the same analgesia dose, and after that, make it an SOS dose. Another thing is, if your patient is extremely cachexic, fentanyl will not work. It needs some amount of fat. If your patient is febrile, is having, spiking, is having fever, again, fentanyl will not work. So the skin condition, the temperature, the amount of fat, all of this is important to decide whether you want to start fentanyl. Again, suppose a patient's pain is unstable, which means that he's fine on one day, he's not on one day. He's spiking in between with pain, he's needing breakthrough doses. You still have not come to a comfortable pain dosage. In that case, fentanyl may not be useful. And if you are going to start titrating fentanyl, especially when a patient is already drowsy due to dyselectrolytemia or in hepatocellular failure, it's not a good idea. So you need a baseline opioid dose before you actually start a patch. Next slide, please. Buprenorphine is another drug. I see patients coming with this sticker very, very often. In fact, many times in the OPD, we actually ask them, how many stickers do you have when they come from elsewhere? And we are first peeling out all those extra stickers that they come with. People, they just put the buprenorphine sticker. It's expensive, 2,000 rupees. It has a ceiling dose. It doesn't work. And then the patient is on injectable SOS tramadol, SOS diclo, and name it, and all these kind of weird combinations. So one thing we should know is it may be a very good drug for post-surgical pain. And it may be a drug when you have established the morphine dose and the patient is in renal failure, and you could give it. But in palliative care, we use very little of buprenorphine. We prefer morphine and fentanyl. Somehow that works much better for us. And there are also sublingual tablets, but they're not licensed for use in pain. It's more for de-addiction. Injectable and transdermal preparations are available, but somehow morphine and fentanyl work much better in a palliative care practice. Next slide, please. And when we talk of potency, codeine is 1/10 potent. Tramadol is 1/5 oral and 1/10 parenteral. When we look at oral, subcutaneous, and intravenous morphine, like I told you, you have to halve the dose for subcutaneous and make it 1/3 for intravenous. Next slide, please. When we talk of potency, there's something called potency, there's something called efficacy. So when we say that, when we talk of efficacy, it is a response which is induced by the administration of the active agent. So the degree of analgesia following dose escalation limited by side effects. So what is the degree of analgesia that you're achieving after you're giving the medications? That decides the efficacy. Potency is more pharmacology. It's a dose-response relationship. So how much of this drug is entering the systemic circulation? How much of it is tying up to the receptors? What is the affinity to the receptors? That is what makes the drug, is the potency of the drug. The next slide, please. So you have, based on the receptors, we have agonists, we have antagonists, and we have agonist-antagonist. And in the agonist-antagonist category, you can have a mixed agonist-antagonist or a partial agonist. Why is this important to know? Next slide, please. So an agonist is a drug which has an affinity and binds to the receptor, and they have no clinically relevant ceiling effect to analgesia. Next slide, please. So this is how the curve will be. As you raise the dose, the analgesic dose increases. The analgesic effect increases in a log linear fashion. So what is the end point? Till either you get good analgesia or you get dose-limiting adverse effects. So that is why when we give morphine, we tell the patient, keep increasing the dose till you get good pain relief or you feel drowsy. Why? Because there is no ceiling effect for morphine. So that is when you have to gently keep increasing the dose till you get this. And that is principally the reason why this is accepted as a gold standard for cancer pain. Next slide, please. So these are the various agonists that we have: morphine, fentanyl, codeine, tramadol. Tramadol not as we don't go beyond. We don't really go beyond 200 milligram. We immediately switch to morphine. Next slide, please. When we talk of antagonists, these drugs have no intrinsic pharmacological action, but what they do is they interfere with the agonist. So what they can do is they compete with the same receptor. So when they compete with the same receptor and compete for receptor sites, then it negates your action of the agonist. Next slide, please. So some of the antagonists are naloxone and naltrexone. So we are now using the methyl naltrexone. We are using the peripheral antagonistic action for relief of constipation. Next slide, please. So when we talk of agonist antagonist, like what I said, this can be agonist at one receptor and antagonist at another receptor. So though they can produce analgesia in a patient who's opioid naive, they can precipitate withdrawal in those who are physically dependent on morphine. And they can give you pain relief, but they can antagonize the effect of another drug. Next slide, please. So now we are back to that question where this all started. We were talking of a patient who was on 50 milligram of morphine and came to you with intense pain. You had injection pentozokin with you, fortpin with you, and what would you choose? Would you choose to go higher on the morphine dose? Would you choose to give another tablet and see how it helps? Or would you choose to give pentozokin injection? Next slide, please. So this is what an agonist antagonist can do. It can actually bring down the pain relief which the agonist has given. Next slide. So pentozokin has an agonist effect at the kappa receptor and it has a weak antagonistic effect at the mu receptor. As we know, morphine is a mu agonist. So when you are going to inject pentozokin, what will it actually do? It will replace the morphine from the mu receptors. So effectively, you are not going to give them better pain control. Instead, it would be better if the patient is responsive to morphine, give them the oral morphine and try and increase the dose to optimum. Look at the other adjuvants that you can add. Look at psychosocial factors which could be responsible for this pain which is creeping up in spite of your increasing doses. Giving them injection pentozokin is not a good idea. Next slide, please. So that is how we talk about choosing the opioid. And if your Mrs. N has breast cancer with brain metastasis and has received radiation, even if she has moderate pain, we will avoid tramadol and we will probably go straight to morphine. Next slide, please. Now, what are the side effects of morphine? The adverse effects with therapeutic doses. Most important is constipation. This is not dose dependent. It is going to stay forever. You will have very few patients who will not complain of constipation. The most important rule is don't allow them to complain. Prevent the constipation. Anticipate it. And prescribe the laxatives. And while prescribing the laxatives, don't just write some kind of laxative. You have to prescribe it keeping the principle in mind. Why do opioids cause constipation? They will stop the bowels from moving. So you need to give them a stimulant laxative. You need to give them something that will soften the stools, or a liquid paraffin which acts as a lubricant. So you need to choose the laxative and give it to them. Don't blindly write lactulose for everyone, because that will not work for opioid-induced constipation. It's very expensive. Patient will not and end up not taking the laxative and hating your pain meds. The other side effect with morphine is nausea and vomiting, but this is an effect which will go away. A couple of days, 2 to 3 days, and usually this effect wears off. And again, don't give them ondansetron. Don't just prescribe Ondem blindly, because that will not act on the receptor which is needed. You will need a metoclopramide, or you will need a haloperidol, which is a dopamine antagonist. So that is what will help for opioid-induced nausea and vomiting. You can always tell them, take it for a couple of days, and so haloperidol or metoclopramide. And after that, if your vomiting stops, you can gently stop the drug. Sleepiness, tiredness can be there in the initial couple days. Some patients get itching, but it's self-limiting. Sometimes the itching can persist, sometimes to a point where you might have to change the opioid also. Dry mouth and urinary hesitancy is seen, and this is more relevant when you give it in the elderly, when you give it in those who already have these problems, and when you are combining morphine with, say, amitriptyline. So then in that case, you're just compounding the dry mouth and the urinary hesitancy. Next slide, please. So like I mentioned, constipation is in 95% of the patients. Stimulant laxative like bisacodyl. Bisacodyl stimulates both the small and the large bowel. You can give this. Next slide, please. Vomiting and nausea. Choose your drug well. Give them metoclopramide, haloperidol or domperidone. Next slide. These are drugs acting on the chemotherapy receptor zone. Next slide. Yeah. Sleepiness and tiredness is self-limiting. Next slide, please. The toxic effects. Now, these were the side effects. You could deal with them and you have something to negate them. But when we talk of toxicity, it is an adverse effect when the administered dose is higher than that required for pain relief, or the patient is taking the morphine and has a poor response. So this patient can present with delirium, myoclonus, or drowsiness. Now, when this patient comes to you, one of the common ways that this happens is that you have not given them a good laxative, or they are not taking the laxative, right? The patient starts getting constipation, starts having abdominal pain and crampy pain along with your medication. And you have told him that if you have pain, you can increase your dose of morphine. So on one side, they're increasing the dose of morphine, and that constipation is never going to respond to morphine. So the patient will come to you saying, I have severe abdominal pain, not pass motion, can even be in delirium or even be drowsy. So your history for constipation has to be a constant in every single consultation. And when you take a history of constipation, it's not just have you passed motion, because you can have impacted stools and the patient can have present to you with spurious diarrhea. You can have incomplete evacuation. So you need to ask, you need the patient to verbalize and tell you whether the motion is soft or hard, whether the patient is having a feeling of complete evacuation, and whether he's having nausea, vomiting with it. Has the pattern changed from before? So these are questions you need to ask in every single session. Myoclonus is also an effect you need to be cautioned about. The patient will come and typically give you, I get these jerky movements, and when you have that, you might have to stop the drug and you might have to switch the opioid. Next slide, please. This is something which all our textbooks have taught us over the years, which we have learned and which we worry about and which we fear about. But with oral morphine and the way we give it, we hardly ever see it, because they take it by mouth, they combine it with gradual increase in dose, and this ensures that this is unusual. We actually give it for dyspnea. Next slide, please. And whenever you have a patient where you feel there is a respiratory compromise, look for something else. Don't blame the morphine. First thing, look for pneumonia. Does this patient have a DVT? Could this be a pulmonary embolism? Or have I given another sedating medication with it? Is it a benzodiazepine? Does this patient have? So you look for another cause. But in our practice, with the oral doses, with the way we gently escalate the doses, we hardly ever see respiratory depression. Next slide, please. Addiction. Now, opioids causing addiction is low. Again, we sometimes tend to confuse with what we call as physical dependence and psychological dependence, which is addiction. We overestimate the risk of addiction. Next slide, please. And because addiction is a neurobiological disease, it has genetic, psychosocial, and environmental effects. So it's compulsive use. But having said that, I think it's important for us to also take a history. It is important for us to know that has this person been addicted to anything else? Smoking, alcohol, this history will help. And if you have the history already, document it. And whenever you give the medication, we always prescribe it for a particular period of time. We give it for 15 days, we give it for 1 month. We take a history, we review. Even if the patient doesn't come back, we talk to them over the phone. So these are things that you need to be clear about. And if you can even try down titrating the morphine, especially in early palliative care, when we start the medications at diagnosis, when the pain is at its peak, patient starts disease modifying therapy. It is also our responsibility to then start down titrating these drugs, take back the remaining medications that is with the patient, and then tell them to follow up. So these are areas of caution, and always taking a history, whether he has history of addiction for something else or substance abuse, is important. Next slide, please. When we talk of physical dependence, it's a state of adaptation by the drug-specific withdrawal syndrome. So what happens is when you're giving morphine to this patient for a long time, and then suddenly his pain he's on disease-modifying therapy, pain is coming under control, he's getting drug. You have to slowly start stepping down. Don't stop it overnight. That is when they have those severe cramps and they're very disturbed and they come to you. So tell them to cut off the alternate doses, then make it a BD, then OD, and then stop the medication. Next slide, please. And most of this in chronic non-cancer pain and opioids, this is one area where I don't really have experience in giving patients with non-cancer pain. And there has been a lot of talk about this in the US, because that is where it went into opioid abuse. And I think we are still a long way away from using opioids in non-cancer pain on a regular basis. And most of these effects were seen when it was given in non-cancer pain. Next slide, please. So the cost per day, if you look at the cost per day, so many a times when a patient is on regular step 2 medication, putting him on tramadol, TID every single day will be very expensive. So there are times when patients have settled on regular tramadol, that is 50 milligram TID, or even needing an extra dose. It may be cost effective to switch them to morphine. It's much cheaper, it's better tolerated. So there's nothing wrong in doing that. You don't have to adhere so much to the step ladder that you cannot give them unless they're going to complain of pain again. You can definitely, between 2 and 3, you can switch. Next slide, please. Methadone, just one word when we are talking of step 3 opioids, is a synthetic opioid. And it's an opioid agonist. It's an NMDA receptor channel blocker. That's why it works very well for neuropathic pain also, a presynaptic blocker of serotonin uptake. Now, when do we choose to give methadone? But methadone comes with a lot of drug interactions, electrolyte disturbances. So we need to be trained, because when you give me a morphine dose and you tell me how much fentanyl is required, I can give you the answer immediately, because it's all a very equivalent kind of calculation. But when you're going to start methadone for someone who's on morphine, the calculations are not so simple. So the titration is not easy. You might need to admit that patient for a week. You might need to taper one drug down and then start the other one. There are different ways that you can do it. But methadone is a very good drug when your patient has toxicity for morphine, when there is complex pain, when there are multiple elements of pain involved, you're not achieving great pain control with morphine, when the patient is on renal failure. These are indications for methadone. But one cannot just give it. You need to train in the drug. You need to really train and then titrate and then give the medication. And there are also drug interactions and electrolyte disturbances. So sometimes when you are thinking of early palliative care and patient is on chemotherapy and receiving chemotherapy medications, which already cause electrolyte disturbances, it might not be a great idea to bring in methadone there. Next slide, please. So this is the last slide. Now the patient is on 30 milligram of 4th hourly morphine. What will be his daily dose of morphine? Can someone shout it out quickly?
Anyone to answer?
Wake up. So if you're on 30 milligram 4th hourly, what is the daily dosing?
180 mg.
36, 180, right. So how would you convert this to SR morphine? So if you want to convert it to a sustained release morphine, what would you do? But a word of caution, what will you write after that? Make sure that you don't bite, break, or chew the medication. Okay, otherwise, if they do any of that, it becomes 90 milligrams immediately. So always that caution should be there.
Dr. Chirag.
Now, you want to switch him to fentanyl. How will you switch him? What would be the fentanyl, transdermal fentanyl patch that you would choose? TD fentanyl patch. How much would you like to give? You could type it out. I was receiving those answers. They were you can type it out or you can shout it out, whatever works. So usually when you want to switch to fentanyl, you go 1/3. Okay, so if it's 180, then the closest would be 60 and micrograms per hour. So the closest patch is 50. It's always better to start on a lower patch. So we could start with 50 microgram of fentanyl per hour patch and add SOS morphine and then retitrate again. How will you calculate this patient's breakthrough dosing? If you want to calculate a breakthrough dosing, what is the breakthrough dosing? Breakthrough dosing would be
30 mg.
Yeah, it is 30 mg. It's a Q4th hourly dosing. Always remember that. It's a 4th hourly dosing is the breakthrough dosing. Suppose he needed a subcutaneous or an IV route, then how would you dose him?
1/6.
1/6
subcutaneous.
So if it is subcut, it's usually 1/3, and if it is, it's usually half, and it's IV, it's 1/3. That's what we usually follow. Okay, of the total dosing. So half of the total dosing. So 180 milligram per day, 90 would become the subcut dosing, and 1/3, 60 would become the IV dosing. Okay, Dr. Sunil, you're most welcome to please add or your inputs.
I think we will straight away go to the doubts because there will be many doubts on opioids.
Yeah.
So I think anybody want to ask any questions, please come up.
How many of you use morphine in your practice?
Just raise your hands if you're using morphine.
Just raise or just... Okay, that's nice. So what are the difficulties you face? What are areas?
Dr. Rahul want to ask it.
Mainly post-op.
Dr. Rahul?
I'm using it for post-op analgesia.
Sorry, you are not clear. Hello, Rahul?
Yes, sir.
Can you speak?
Yeah, I'm using morphine for post-op and intra-op analgesia.
Okay.
And not for chronic pain. As a tablet, I'm not using.
Okay. Anybody else? Dr. Jitin?
I can read a couple of questions which says non-compliance and nighttime pain. Somebody has asked that.
Dr. Srinidhi have asked.
Yeah.
Is it?
Yeah, and they take it as an on-demand drug and not round the clock. I think that's where your counseling is paramount, because when you give them the drug, tell them that this is for cancer pain, this is the gold standard, it will work only if you take it round the clock, and find out what are the limiting factors. One is they cannot read the time. It happens. So you prescribe, but they cannot read the time. Second, they live alone. The others go to work, so there is somebody who can't give it to them every 4th hourly. If there is a youngster, try and put an alarm in their cell phone. So non-compliance, the only way you can go around it is to find out why they are not compliant to the drug. And nighttime pain, yes, nighttime pain, you need to give them, you always have to tell them to keep a breakthrough medication along with them. And most important cause for nighttime pain is they don't take a double dose. And one more thing that happens is you would have started the patient on 5 milligram 4th hourly and told them to take one tablet in the night or 10 milligram in the night. So you'll say half, 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 one. The next time when you raise the dose and make it 1, 1, 1, 1, 2, the 1 stays as 1. Somehow the nighttime dose, they don't double it. So every single consult, please ask if they are doubling the nighttime dose. So tell them that, clear these things for them, explain 4th hourly. It takes time, and there are times when patients have taken morphine for a long time, but still they become non-compliant at some part. And as an on-demand drug, tell them it will not work when you have pain. That's the only way you can put some fear into them and tell them that they have to take the medication on time. And do you entrust the patient or the caregiver? Both. If the patient does not understand what he or she is taking, you are doing them a disservice. And please make sure that the caregiver who has accompanied the patient is the caregiver who will be staying with the patient, because many a times they are both different. So these are the questions that you need to ask. And we don't give we don't get kidney problems with morphine unless they have a kidney problem. Then you bring the morphine down. Longest duration we have given morphine, for me in my practice over here, I have given it for 2.5 years to the patient. The patient died after 2.5 years, and there are patients who are taking morphine regularly for 1 year or more. There are many patients who are taking it for 1 year or more, or for months or more. But again, monitoring the dose. Dr. Sunil, please add whatever you would wish.
I think GCRI has a question. GCRI? Can you unmute yourself?
Yes. Ma'am, what do you mean by contact time 6 hours while giving oral sublingual morphine?
Sorry, can you repeat that question?
Ma'am, what do you mean by contact time 6 hours? You told in your slide. While giving
Okay.
morphine, sublingual morphine.
Okay, Vidya, did you hear that?
I didn't speak about sublingual morphine. I said about buccal. Yeah, it takes about 6 hours to get absorbed from the buccal mucosa. There is no sublingual morphine. There are times when we have to crush the tablet and mix it with honey and put it into the buccal mucosa, because that is the only route we have. There may be a time. It takes a longer amount of time to get absorbed. That's okay.
I just want to add a point here. According to European Association of Palliative Care, buccal and gingival route is not recommended because as Dr. Vidya told, it may take long time, and we are not sure whether it is absorbed sublingually or by some other methods. But when you keep something in the mouth sublingually or gingivally for a long time, there is a possibility that it will be swallowed, and most probably the pain relief, if it is there, it is due to the oral absorption. So that's another thing that we need to be careful. So the parectal route is an important route which we can select for patients who are unable to take orally. The parectal route is as comparable to the oral route, and some people say it is much superior to oral route.
That is why towards end of life, we always, or if the patient has admitted with us, or we can give it, we prefer the continuous subcutaneous infusion.
There is another chat question. What is the role of morphine in acute chest pain in myocardial infarction?
We are giving around 0.1 milligram per kg body weight, and if it is patient needed after 10 minutes of action, 1/3 dose or half of dose can be repeated for MI patients.
Okay. In MI, definitely morphine is indicated, but the optimum dose, I don't know, because we are not working in an acute care setting. Yeah. Dr. Anandakrishnan has written that not given if there is hypotension.
If I fail to relieve constipation.
If bisacodyl failed to receive the constipation, what can be done next? Okay. Dr. Vidya?
Yeah. Now, usually with laxatives, the instructions that we write is we have what is called as a combination laxatives also. So the laxatives we choose are the most commonly what we use is Clemafin P because that has a lubricant. It has sodium picosulfate, which acts as a stimulant, and it also has magnesium and aluminum hydroxide. Now, the other one, bisacodyl, is our stimulant laxative. So first, what is the dose that you're using? So if they are taking just one tablet at night, comfortably make it 2 if it is a 5 milligram tablet. Increase it to 2 tablets at night. Tell them to then combine it with liquid paraffin. So they combine it with 2 laxatives. Okay. So, and the upper limit of laxative dose is something that comes only by adjustment. So usually on my prescriptions, I write start with 15 ml HS, increase up to 30 ml HS, and or bisacodyl 2 tablets in the night. If all this also doesn't work, then we prefer to give what is called as polyethylene glycol, all the PEGs. They really work well for impacted feces. So we give the PEG move. And if this doesn't work, we go on to the suppository. So suppose someone is having a problem with constipation, we tell them to use combination laxatives, usually Clemafin P, bisacodyl, and then add PEG move, say twice in a week or once in a week, because that helps with fecal impaction. It's also expensive, so that's why keep it on the lower side. Add a rectal suppository also. But if after trying all of this, patient has to have enema, has a very severe problem with that laxative, and you're sure you've optimized all the doses, all the medications, then we think of switching. Otherwise, when we use combinations, it usually works. Dr. Sunil, anything more?
Okay. So as Dr. Vidya told, optimizing the oral laxatives would be the first step. And you can also give interfere with parental things like enema or suppository would also benefit the patient. And if there is resistant constipation, it is said that methyl naltrexone, injection methyl naltrexone can be used, but it is not available in India. But in the Western countries, they are using methyl naltrexone. GCRI?
Yes. I had question of naltrexone only. Ma'am mentioned in her slides that about naltrexone. So wanted to know that only.
Actually, now there is an oral for opioid-induced constipation. One of the drugs is methyl naltrexone, which is subcutaneous use. And there is also naloxegol, which is a pegylated form of naloxol, which has come into the market again in the West. That is the first oral medication for opioid-induced constipation, but we don't have it out here. We don't get it here.
So what is the role of high fiber diet in the management of constipation?
How many of our patients in palliative care are able to take a diet, and that too a high fiber diet? I think we need to ask ourselves that question first, because most of our patients are unable to eat. So a high fiber diet, if you can always recommend it for somebody who's PS1 taking medications, but otherwise that's a tough call for the patients we usually see.
GCRI?
GCRI team, have you?
No, sir. It's clear.
Anybody else has any more questions? Okay, thank you. So let's move on to the patient story. So Dr. Madhurika, who is the clinical oncologist from Coimbatore, will be presenting the patient story. Dr. Madhurika?
Good afternoon all. Hello.
Yes, doctor, we can hear you.
Good afternoon, all. So, I'm a clinical oncologist working in PSG hospitals. So, let us start with this patient. He's a 48-year-old gentleman. He is diagnosed as a case of metastatic stage 4 carcinoma lung, and he presented recently to our OPD with a progressive disease and some neurological dysfunction. Next slide. So this patient is a known case of stage 4 carcinoma lung with pleural secondaries. And he has completed his chemotherapy and radiotherapy, but defaulted for 2 or 3 months. And he suddenly presented to the OPD with difficulty in using both lower limbs, maybe say for 15 days, but is progressively increased so that now he's completely unable to use the both lower limbs. And back pain, severe back pain, headache and vomiting, and some amount of drowsiness with some bladder and bowel dysfunction. So this gentleman initially came last year with complaints of cough with expectoration for 3 months, dyspnea on exertion for 2 months, and weight loss for around 6 kgs over a period of 3 months, and some right-sided chest pain, which was intense and pricking for 20 days, with decreased sleep, loss of appetite, and he also had history of smoking for 15 years. With this history, he was evaluated for tuberculosis, bar a malignant disease. So on evaluation with imaging, an X-ray chest was done which showed a mass lesion, and further a CT showed a mass in the right upper lobe and some mediastinal nodes. And he had undergone a biopsy, and histopathological examination showed an adenocarcinoma of the lung. So this was initial diagnosis. So next slide. So the treatment history is, so in the last September 2018, this gentleman was diagnosed as a CA lung adenocarcinoma stage 3. So he was staged as T3N2 stage 3 disease. And we had counseled the family regarding the treatment, saying that he would require concurrent chemoradiation, which is nothing but giving chemotherapy and radiotherapy together. But what happened is, after a span of around 1 month of taking 20 fractions of radiation and just 2 cycles of chemotherapy, he had a very symptomatic improvement. That is, his cough, his dyspnea, everything subsided, his pain has come down, his weight has increased, so he was able to eat. So he defaulted for treatment after a symptomatic improvement. And later in January, say after 4 months, he presented again with the same symptoms like cough, dyspnea, and chest pain. And we have done a CT chest on him, which showed a progression of disease and also some new lesions in the pleura. So now he presented with a pleural effusion. But there were some logistics for doing a PET scan. So we staged him as a metastatic disease with pleura and staged as stage 4 M1A. And now his treatment modality has changed from a curative intent to a palliative chemotherapy because EGFR mutation was negative. And even now, after 2 cycles, he had some improvement as pleural fluid was drained and his dyspnea, cough, everything subsided. This patient defaulted again. So later now in June 2019, he presented to our OPD with a neurological symptom. So he's a frequent defaulter. Now on examination, he is conscious, his higher functions are normal, his vitals were normal, his performance status is 3, he was brought in a wheelchair because he was not able to use his both lower limbs. And general clinical examination, there was no cranial nerve deficits, both his upper limbs powers were normal, but lower limbs, there was 1 to 2 grade of power bar 5, and sensory functions, it was totally decreased to say no sensory functions in the lower limb, and bilateral plantars were extensor. Next slide. So we had a clinical suspicion of brain secondaries with increased intracranial tension. So we started immediately on mannitol, injection DEXA, and some IV fluids, and we did some basic blood investigations like complete blood count, some biochemistry profile, and to see for serum electrolytes. And MRI brain with whole spine screening was done, which turned out to show a multiple brain and spine secondaries. So the treatment plan was, now having a brain secondaries, the very poor prognosis, and the outlook was discussed with patient's wife and son, and the immediate need for whole brain artery to decrease the intracranial tension was explained, and further what would he need was palliative bar a best supportive care. But once we explained to the family that his life expectancy is very short with the brain secondaries and the requirement of radiotherapy and chemotherapy also, they were not willing for further treatment and hospital care. So they said they don't have enough money to spend, and the life expectancy is very short, so they don't want to spend that time in the hospital. So we just put him on some oral medication, some oral anti-edema measures with steroids, and some anticonvulsants like Keppra was given, because there was no bowel and bladder control. Bladder was catheterized and the patient was discharged home. Next slide. So the psychosocial aspects which I would like to highlight was, it was a nuclear family and he was the only breadwinner of the family. So that was the reason for his frequent non-compliance to treatment, because only if he works, he can meet the daily family expenses. So once when he had some symptom improvement, he wants to just go back to work and then earn money. So that was the problem for his non-compliance. So he has a wife who was a housewife till now, and he has a son who's studying in college. So he's the only person who has to meet the daily family expenses, and also hospital expenses like imaging, the blood test, and supportive medications, what all we prescribe. But chemotherapy and radiotherapy we were able to arrange and give it under government scheme. But all the other extra medications he has to buy. And he also has to travel to the hospital some 4 to 5 hours, and he has to bear the travel expenses also. Since he started taking treatment, he couldn't go to work regularly. So his wife started working as a housemaid. But because of his illness, she also had to take frequent offs, which was not possible for her to accompany him, because that was the cause for his frequent non-compliance. He says, my wife also started working, but when I have to come to the hospital, she has to accompany me. Because she is taking leave, they're not allowing her to take leave. So that is why I was not able to come to the hospital. And now knowing that he himself realized that he's got some progression of the disease, and he understood that now he's become paraplegic and he's got some problem with his brain. So he's worried about his prognosis and lifespan. Next. So his main concern was now about the prognosis. Till now he never worried about the prognosis because he was ready to work leaving the treatment. But now with the progression of the disease, he understood that something is really wrong, and he's worried about the prognosis and outcome. And even now there is nobody to support the family financially, because it's a nuclear family. None of the patient's family members are helping him out. And he's also worried about his son and wife, because son needs to get education. His wife is still now a housewife. Only now she started working out. And since the bladder is catheterized and he's paraplegic, he's dependent on somebody for his even self-care. And his wife has to stay at home to take care of him, and now she's not able to go to work, and he's worried about his son's college fees also. So we have a 49-year-old gentleman with stage 4 carcinoma lung with brain secondaries and some neurological dysfunction, with an expected median survival of only 4 to 6 months with brain secondaries. So discussion points were, we saw the progression of the disease of this gentleman. Could have been done, what could have been done better to make him more compliant to the treatment, so that at least he would have completed his intended treatment and has decreased the progression to brain secondaries. And now that he's got a progressive disease, and we know that his median survival is going to be only 4 to 6 months, can we do something to improve the quality of life of this patient? And his family is without any support. How can he support his family? Thank you.
Thank you, Dr. Madhulika, for presenting an important problem which we frequently come across. So 48-year-old man with carcinoma of the lung, stage 4, with brain secondaries. So the first question was, what could have been done for more compliance? But all of you are working in your respective fields. So what would you do for a patient like this? Dr. Geda, I think you might have seen many patients, especially pediatric patients, who is having chronic illness, and are they coming for regular follow-up? What is your experience? Dr. Geda, please unmute. First.
Feel they will get some benefit, they'll come for follow-up.
Sorry, we didn't hear you. Can you?
I'll type it. I will type it.
Dr. Geeta, we were unable to hear you. Yeah. No, no. The problem was you were muted, so that's why we didn't
Okay.
hear you. So
Okay.
can you?
Only if the patients or the family feels that they will get some benefits by coming, they will come. So we should give them some support. For example, in this patient, already they know that there is no cure. So that is why probably they are poorly compliant.
Okay. So GCRI team, what's your experience? Please unmute yourself and speak.
Actually,
Doctor, we have lost you. Can you hear us? I suppose there is some internet connectivity problem there. So anyone wishes to answer?
Anybody else? Yeah. Sorry, GCRI team, we didn't hear you.
hello.
Yeah. Now you are audible.
Yes. Actually, I didn't get what you were asking for.
Yeah. Have you seen any patients who are not compliant with the treatment?
Yes. Before coming to our department, patients may be non-compliant to the treatment. But once it is patient he or she is referred to palliative medicine, then there is no problem of compliance. We take care of their symptoms while radiotherapy or chemotherapy so that they complete the treatment after palliation.
Okay, thank you. Anybody else has any comments on this non-compliance part? Dr. Rahul?
Patients and attendants should be informed prior to starting treatment that you will be feeling comfortable after the chemotherapy. You comply with the treatment to completely or have the beneficial effect on you. You have to adhere to the treatment. Should be prior to starting chemotherapy. It should be told to relatives and so.
Dr. Vidya, would you like to comment on this?
Yeah, this is a situation that we do see, and patients non-compliance, we call it patients non-compliance, but I think it's also when we talk of early palliative care, this is one of the things that would be very much part of what a palliative care team can add. First of all, Dr. Madhulika, that was a very nice presentation, and I could feel that, you know, how terrible you felt when the patient did not come back, and from a curative you had to now convert to palliative chemotherapy. Not, you know, how he deteriorated in front of you, and I can see your, you know, how much you feel about that. So I think when you give an early, because as an oncologist you have your own practice, and you have your huge strengths. So that's when I feel if we integrate early palliative care, and that's the importance of integrating it at diagnosis, or when the patient has breathlessness, we start medications. And so you have two departments which will kind of keep track of him. And maybe these are patients which will be on a high priority tracking list for palliative care. So if they do not come on the dates of chemotherapy, or when they can, maybe the team could find out, do a home care, assess. And if these psychosocial, because things haven't changed, they had to travel 4 hours from the day they came for chemotherapy. So the palliative care team has its own strengths. We identify these areas. So if we can start by supporting the son, providing them some provisions at home, and ease their life a little, and that again, like what Ms. Geeta has written, NGO support. So if we can have a little connectivity with an NGO, with a PALCare team, which knows where this is coming from, how we can help, that would add a value to the practice, because we sit in a hospital, see patients every day, but we don't know who comes back or not. But a palliative care team and NGO can probably contribute to improving compliance. And there is also evidence that good symptom control makes them compliant to chemotherapy. So we don't know what his fears were, what his problems were, why he didn't come. So that's one of the thoughts. And yeah, the second and third we'll go to later when Dr. Sunil asks.
Yeah, thank you, Dr. Vidya. And from Dr. Madhulika's presentation, it was clear that the patient could not come or was not compliant with treatment because of the financial situation. So, as everybody told, it would have been better if we can arrange some support for the patient, if there is a connection with NGO, or if we have some volunteer support. All those will make difference, and early integration of palliative care into cancer care will also make a difference. So many of the anxieties and finding out the problems faced by the patient and family and providing psychosocial support, all this will improve the compliance with treatment. Okay. Next question. Great. Now with a progressive disease, what can be done to improve the quality of life of the patient? Yeah. What can be done to improve the quality of life of this patient? Anybody? Yes. Okay, Dr. Geeta has written food which he likes should be given. What else? What can improve his quality of life? Peace of mind.
Hello. Hello.
In Nigeria, most people don't have health insurance. What's your advice? Okay. So we also, in our country also, we don't have health insurance. So it's mainly from our pocket, we have to spend money for treatment. So somebody else, okay, GCRI?
Here, we can give good symptom control, and plus for socio-economical purpose, we may send them to some NGO or in our institute. At GCRI, there is no problem of economical issue because all patients are included in government scheme every time. No problem of transportation also. We provide them transportation pass also. But for his son's study and for some earning, we may help through NGO.
Okay. Dr. Vidya?
Now, here, if you have to improve his quality of life, there are two aspects to it. One is his physical quality of life, and the second one is the psychosocial concerns. So the part 3 of the question will also go in improving his quality of life. So is there a way that his family can be supported? When he's alive, is there a way that he gets to know that his son's needs will be taken care of, maybe through an NGO or through a donor? Can his wife's job be such that, you know, she can manage him at the same time work, because that's her only means of livelihood? Can we provide good home care for this patient and improve the quality of life? Because it's not possible or feasible for that patient to now travel to hospital. So we need a very good home care service. Does he have access to a hospice in case he needs it? And then can we give him a wheelchair? Is there a way that he can sit and be moved around? So can we arrange for a wheelchair for this patient? And can we make sure that he doesn't have bed sores? Can we make sure that his pain is controlled? And can we make sure that his symptoms, because once he has mets in the brain, it is very, very difficult. In fact, I shudder. The first thing I tell them is, please go for PAL-RT, and I literally beg the radiation oncologist, because it's one of the worst symptoms to manage. because you might have to keep on switching between giving steroids, giving mannitol for 3 days, and then again the patient settles. You may never be able to taper the steroids. Then he'll go into infection. Then he will have candidiasis. There are so many of these things which will keep happening. So we need to provide continuity of care physically and psychosocial aspects, give support to the family, find a donor, or, and these things to be done when he is aware. So that kind of brings down his spiritual distress. I mean, these are some of the thoughts.
Thank you, Dr. Vidya. So to add to that, one of the important thing that we should remember is quality of life is decided by the patient by himself, not by ourselves. So we have to ask the patient, what can we do to improve your quality of life? There are many concerns that is raised by the patient here. So one of the problem, there are many problems. So as Dr. Vidya told, physical and psychosocial problems. So when the patient is discharged and the prognosis is very poor, his wife is going out for job. But if we can do something, if we can arrange some vocational rehabilitation for the wife, which can be done from the house itself, so that the wife can sit with the patient, which will be one of the important thing. And son's education is another important thing, which we can take care of by involving some of the NGOs or with the help of volunteers. Anybody has any or questions? Dr. Madhulika?
Yes. Hello.
Yes, Dr. Madhulika.
Yes, sir.
Do you have any more questions on this?
I mean, we always talk about involving NGOs in so many things, but the real practicality is we can give them some psychosocial counseling. We have a counselor who will give them, and we also had a track of patients. We usually take their appointments, so we check their appointments. We call them back, but each time when we call back, the connectivity problem again. They say, "I have work today, but I have work," but somebody else has the phone, so they keep switching on, and they while away. Even though if we try to keep a track on them, but they find firm reasons to say not coming to the hospital. And involving NGOs in giving financial help to the patients, it doesn't happen very easily. So they are very choosy in choosing only, as Geeta madam said, pediatric patients. They are more interested in pediatric and curative patients rather than these stage 4 metastatic patients who have a very small or a shorter overall survival. They decide upon whom they should help. Like patient's financial status and everything is taken into consideration, but age and also the intent of treatment. If we say if it's a curative patient, they're ready to help. But if it's for a metastatic palliative patient, they take it back because their resources are wasted. They mean it that way. So it doesn't always happen that involving an NGO, they help all the patients out. So pediatric patients and curative patients, they are given the priority compared to the palliative and older age group patients.
Yes, Dr. Vidya.
Yeah, you are very right, Madhulika, and so that's exactly why I think working in teams helps, because one can't do, someone else can always achieve. We may not be able to do everything for everyone, but if we start working as teams, we will definitely achieve a little bit more. If you can only, and I think that is where, when we start with the counseling, it's not just about the disease, it's about, how is your family, what will help you to bring you to the hospital. More important is not what we are giving them, is to find out why they are not coming. Why are they not coming? Are they able to understand? Do they have an insight into their disease? So these are things which palliative care does all the time. Like, we keep on asking them that. So working with someone else is a huge advantage, because very honestly, in this patient, I would have pushed for palliative radiation, because it's so hard to manage patient with brain mets and spinal mets without radiation. it can get really bad, and they don't just die very soon sometimes. So when we work with a team, I think we try and find balance in some ways. But whatever you said was very true. There's nothing in the it's a problem we face all over the country.
Thank you. I think GCRI has a comment. No? Okay. So I think it's time to close this session. So a few things which we discussed in this patient story are integration of early palliative care into cancer care, and looking at the physical and psychosocial factors of the patient, and do whatever possible for us, and working as a team would do much good for the patient, because everybody can contribute then. And vocational rehabilitation of this for this patient family would be another thing which can add to quality of life. But definitely the quality of life is defined as per the wish of the patient, or the patient is the person who need to tell us what is the quality of life which he need, and what are the components of quality of life. So thank you, Dr. Vidya, for being with us today, and thank you all for having a very good interactive session, and thank you, Dr. Madhurika, for presenting the patient story. Thank you all.